Hospital in Aurora, Colorado. And the I am Julie Swaney and am moderating our session today. And really pleased that you're with us. Just a housekeeping piece is if you would please put your questions or your comments in the chat, then I will address those to Dr. Copeland at the end of her talk. But really very pleased to have Darcy Copeland with us today. Darcy is a nurse and a professor in the Department of Nursing at University of Northern Colorado. She is a nurse scientist at St. Anthony Hospital in Lakewood, Colorado, and an active member of the University of Colorado Hospital Ethics Committee. And we really appreciate, Dr. Copeland, the many contributions you make to advancing ethical dialogue in the clinical setting, this topic among them. Our topic today is on caring in the context of patient violence, something that I think we all, unfortunately, know something about in terms of the patient violence. And Dr. Copeland's going to help us think about that in terms of the ethics. She's going to speak about 4 types of workplace violence, discuss approaches to them, and then identify 2 ethical frameworks to frame our discussions regarding patient violence. So again, thank you, Dr. Copeland. I will turn this over to you and appreciate your leading us in this discussion.
All right. Thank you. And thank you, Julie, and the ethics committee there for inviting me to do this presentation. It is a topic near and dear to my heart. Sorry, I'm trying to share my screen here. It's a topic near and dear to my heart. I've been researching violence in general, but workplace violence in particular for many, many years. So I could talk about this stuff to anybody who will listen. So thank you. So let me just, as I wanted to start with a disclaimer that, as Julie kind of mentioned, what I will be talking about mostly is how we talk about and frame patient violence versus how we might prevent it. So this is kind of an ethics focused. I might, throw in a little tidbits here and there, but the focus is really on how we talk about and frame it. And really, I will probably heavily advocate for the insertion of ethics into discussions about workplace violence in general, but patient violence in particular. I also, just as a reminder, want to restate that I'm a nurse, and some of my languaging, some of my slides will specifically reference nursing, but there is wider, broader applicability. So insert your own disciplines as appropriate. I wanted to start with a little bit of a kind of what I would call a lay of the land, just to ensure that we are all on the same page about what we're even talking about when we're talking about workplace violence. The term workplace violence, in my experience, is used as a monolithic term, when in fact there is a lot to unpack. So I will start with just a little bit of background. I probably don't need to go into too much detail here to let you all know that violence in healthcare is a national problem. It seems to be worse for a variety of reasons. There are probably some social reasons. We are a community society recovering from a major national trauma that was the pandemic. Stress and anxiety were at all-time highs. People's ways of coping were disrupted. There has been some normalization of disregard for others, some prioritization of individuals over communities, a narrowing of filters, polarizing language, etc. There are also clinical factors that might be contributing. We have an aging population. We have a rise in substance use disorders. Acuity in healthcare facilities is higher than it's been in the past. Those are probably some clinical things that are happening. There are policy and finance things that are probably contributing to a little bit of a rise. We have a massive lack of substance abuse and mental health services across the country. We also have a lack of long-term care services, which is probably contributing to some of the violence we're seeing in inpatient acute settings. We have also probably lagged a little bit in how we're responding and adjusting to the higher acuity of patients we're seeing in our acute care facilities. So there's kind of a lot happening. I want to definitely frame that violence that occurs in healthcare settings is very complex. And anybody who studies complexity science would tell you that complex problems require complex solutions. So I would encourage and kind of ward against attempts to standardize and universalize in general, because it is a very complex phenomenon. And then finally, I would also add that there is absolutely and positively a moral or ethical component. We're inherently talking about humans in relationship to one another, usually in the context of highly emotional circumstances. So morality definitely comes into play. I briefly want to touch on the 4 different types of workplace violence that people who work in the workplace violence world will refer to. Type 1 workplace violence is workplace violence that is based on criminal intent. So this is literally somebody who comes into, I'm going to use hospitals as a reference, who comes into the hospital with the explicit intent of committing a robbery. Type 2 workplace violence is violence that occurs in workplaces that is committed by customers or clients. In our case, that would be patients, their family members, or any visitors. And this is the most common type of violence that occurs in healthcare settings. Type 3 workplace violence is worker-on-worker violence. So this could be lateral violence, it could be bullying, it could be hierarchical, but the people involved are all employees of the organization. And type 4 workplace violence is violence of a personal nature. So this is referring to like domestic or familial or interpersonal violence that is sort of in the community that then sort of spills into our workplaces. So those are the 4 different types of workplace violence that exist. And understanding that there are different types of workplace violence really helps us understand what appropriate prevention, mitigation, and response mechanisms might be optimal. So with respect to violence, type 1, workplace violence, a criminal justice and police response is 100% the most appropriate response, as would be the case with familial or community violence that spills into our workplaces. The absolute most appropriate response would lie in kind of criminal justice. Worker-on-worker violence, it may rise to needing to involve the criminal justice system, but we also have employee codes of conduct, professional codes of conduct, just culture algorithms that can help us navigate those instances. So of these 4 types of violence, determining how to respond and what to do about it definitely is most fuzzy with respect to type 2 workplace violence. And in particular, how should we respond and how should we manage and mitigate patient violence? When visitors or family members become violent, involving security, police if necessary, is an extraordinarily appropriate way to manage that. When patients become violent, though, we have to consider some type of clinical intervention. So a brief note on the idea of prevention. I want to reiterate that I'm talking about patient violence, rarely comes out of nowhere. It is exceedingly rare that somebody is talking and communicating like I am here now and suddenly, throws a punch at somebody. That is extraordinarily rare. It rarely comes out of nowhere. And there is well-established risk factors for violence that occurs in healthcare settings. These have borne out repeatedly in research. So there are contextual factors and clinical factors. Some of the contextual things that we know increase the risk of violence happening in healthcare settings are things like wait times, people being uncomfortable, a lack of staff training, a lack of actual staff, how close we need to get to the people we work with, people receiving inconsistent or contradictory messaging. Those are some of the those are some of the contextual things known to increase the risk for violence in healthcare settings. Clinical things that we know increase the risk for violence in healthcare settings are drug and alcohol intoxication, drug and alcohol withdrawal, altered mental status caused by whatever. It could be psychosis, delirium, strokes, dementias, TBIs, coming out of anesthesia, electrolyte imbalances, whatever, doesn't matter. Pain, confusion, fear. So again, these are known risk factors for violence happening in healthcare settings. And I would ask all of you, I wish I could see you, but I would ask all of you to just think about how many patients in hospitals are experiencing one, if not more, of these things. Most likely the answer is very few, if any. This is the picture of a hospitalized patient. Add on top of that nobody who's in a hospital is functioning at the top of their game. Stress, uncertainty, discomfort, all of those things inherently lead to diminished coping in everybody. So that's kind of the picture of who we serve on a day-to-day basis. And I also want to remind people that despite all of this, most of our patients will not behave in a violent manner. And it can be easy for us to lose sight of that. I think it's this kind of that Pareto principle that 20% of our patients occupy, 80% of our time and resources. That's probably true in this case as well. I want to touch briefly on the idea of zero tolerance approaches, zero tolerance policies. Again, and I'm approaching this really from an ethics standpoint. So my first note of caution with respect to zero tolerance approaches is very much, and I hope there's some, maybe social psychology people on the call here. Words matter. The words we use matter and have implications. And that how that can be turned around is that perhaps rather than starting from a place of zero tolerance, we might start from a place of messaging our values and how we want people to behave in accordance with those. So we start with we are a healing environment that aims to provide, the best patient care to everybody in our community. And we will treat you with dignity and respect and ask that you do the same to us. Is an extraordinarily different message than we have a zero tolerance approach. So I firmly believe that the words we use matter. Zero tolerance policies inherently go into effect retroactively. So if you are needing to enact a zero tolerance policy, the violence has already occurred and you've done nothing to prevent it. And to that point, there is absolutely zero evidence linking zero tolerance approaches to any reduction in violence in healthcare. And I literally mean zero evidence. They are based on models that we adopted from the criminal justice system, in particular the broken windows theory, which came to us from James Wilson in the 1980s. And he advocated for maximum punishment for minimal criminal offenses, with the theory being that if you maximally punish minimal offenses, you will be preventing more serious offenses. So that's the model that these policies came to us from. We also all have very different levels of tolerance. So I'm going to use Julie as an example. I might have a very different level of tolerance than my coworker Julie does. So deciding on where we sort of set our mark of zero can become very confusing to decide where that cutoff is. I would also encourage us to think about what is the purpose of our zero tolerance approach or policy or language? What is the purpose of that? In many cases, I kind of suspect, well, I'm going to reiterate that there's no evidence that they prevent anything. So we're just going to throw out the idea that they prevent anything. In many cases, I suspect that what we want to do is have a mechanism to remove people from our organization, which in the context of type 1, 3, or 4 workplace violence is very relevant. We need to have mechanisms that we remove people who are there committing crimes from our property. So if the aim is to get people out of our hospital with respect to patients, I would propose that a well-articulated dismissal policy is probably a more effective way to meet that aim. I also want to point out that there is growing evidence that this messaging may actually be contributing to an escalation of situations, and it might also be creating an intolerant workforce, and that is research that's coming out of Australia. That's pretty interesting. So more kind of potential considerations with the idea of the thinking being we need a mechanism to hold people accountable. I just want to point out that we have many exceptions to the idea of accountability, and many of them are related in some way to mental status. So in our legal system, even, we have languaging about people can be, not guilty by reason of insanity, people have diminished capacity, people are under duress. So we have this kind of languaging that needs to be taken into account when we're talking about accountability. This is even true of the proposed federal legislation that wants to make federally assault against a healthcare provider a felony, which is, it's a fine policy to promote. However, there is language in there that very specifically says if the individual knowingly and willingly assaults a provider, and that is rarely the case when it comes to patients. So if that legislation is intended to impact patient violence, I can almost assure that it will have exceedingly minimal effect on patient violence. Other considerations is that zero literally means zero. If you have a policy that you are making exceptions to, for example, I'll list some here, you are not following your own policy, and a poorly instituted policy might be even more damaging than not having a policy at all. So if I have a zero tolerance to, punching, I pick a behavior, punching, and I apply zero tolerance to it. And it doesn't matter if it is a frightened 7-year-old or an 83-year-old who is delirious, who punches me, it doesn't matter. Zero literally means zero. I fear that zero tolerance languaging also might convey false options to healthcare providers. I have heard many times that, healthcare providers want to kick patients out of the hospital. These patients need to be removed from our hospital. In some cases, that might be an option. There are also situations that is probably really not a realistic option. If these policies are instituted, I think it's very important that somebody keeps track of how they are being applied to ensure that they are being applied universally and that some populations are not disproportionately being targeted by these types of policies. And then I would also throw out, again, with this kind of new information coming to us, do we really want to create an intolerant workforce? Or do we want to work for an intolerant healthcare system? I think that's worth at least considering when we're talking about our languaging. I also have a lot of concerns about the potential for stigmatization. So in particular, I would love for all of you to just take a couple seconds to think about whether or not there are certain medical diagnoses or conditions that might predispose a person to have an increased risk of behaving in a violent manner. So think of one or two or three diagnoses that the diagnosis themselves might predispose a person to behave violent, have an increased propensity to behave violently. Then I would ask you, how many of those are not brain disorders? I wish I could see a show of hands, but I strongly suspect that most of the things we think about are in fact brain disorders. So then I would ask the question, if certain medical diagnoses literally predispose people to exhibit certain behaviors, should our response to that be a punitive response first and foremost, or a clinical response? I would suggest that we should potentially reframe the primacy of our efforts on clinical response. So that's kind of my lay of the land with respect to how workplace violence researchers talk about different types of workplace violence. 4 different types of violence. We talk about prevention efforts, mitigation efforts, recovery efforts, and some thoughts on zero tolerance policies or approaches or languaging. So I'm going to move a little more into kind of strictly ethical landscape here. So I hear in the work I do, oh my gosh, I'm so sorry. Very touchy mouse there. I hear nurses say things like, we wouldn't accept this outside of the hospital. Why should we accept it here? And even some of the federal legislation equates nursing with flight attendants. That languaging is very much out there. And I want to suggest that we have that different relationships that we have in society come with different moral sensitivities and ethical obligations. So in particular, healthcare providers have very specific duties to patients. We have a fiduciary relationship with our patients, and we cannot equate the relationship between a flight attendant and an airline passenger or a grocery clerk and myself to healthcare provider-patient relationship. Those are false equivalences. As professionals, we possess specialized knowledge and skills that we are supposed to use in service to society. So we can't make those equivalents. We also have a healthcare system that is designed in a way that gives patients rights to expect treatment. So patients in our healthcare facilities have a right to expect treatment from us as professionals. And anytime we invoke a right, that sort of indicates a claim on the behavior of somebody else. So it implies a corresponding obligation on the part of another person. In this case, that would be us as healthcare providers. So if a patient has a right, I as a professional healthcare provider have an obligation. That's how that relationship works. And I want to be clear, I am not saying that patients do not also have responsibilities. They do, but they do have rights. So a little more on kind of just navigating duties. So there are 2 types of duties that we can talk about. So there are general duties. These are duties that we all have to one another as members of society. They're not based on any particular relationship. They just exist because we all live in the same society and have agreed to them. Professionals, however, have specialized or enhanced duties. So these are the types of duties that exist in the context of certain relationships and certain roles. And special or enhanced duties can literally obligate people to incur greater risks than those that are imposed by general duties. So some examples of enhanced duties that we have, for example, that the public doesn't, we have a duty to maintain confidentiality. The public does not. we have a duty to, well, I as a nurse have a duty to perform CPR if I see somebody who needs it. A person from the general public doesn't have that duty. So professionals have special or enhanced duties. I'm gonna definitely get nursing here. So in terms of professional duties, the American Nurses Association has outlined the following 4 criteria to help us understand whether or not we have a duty or a professional obligation. So number 1, the patient would be at significant risk of harm, loss, or damage if the nurse does not respond or assist. The nurse's intervention or care is directly relevant to preventing harm. The nurse's care will probably prevent harm, loss, or damage to the patient. And the benefit the patient will gain outweighs harm the nurse might incur and does not present more than an acceptable risk to the nurse. I will be the first to admit that we would need to unpack and have a little more discussion and definition about what constitutes harms, what constitutes benefits, what is acceptable, what is not acceptable. However, this is a good starting point. So the next question we might ask then is, how far does our duty to patients extend? How much risk-taking is required in my professional role? So our duties are not indefinite. There are upper limits to our duties. So how do we decide what the upper limits are? There are 2 things that can help us determine where our kind of upper limits with respect to duty is. One is source of duty. So the source of our duty comes, number 1, from our training. Again, we literally possess knowledge and skills that are intended to be used to serve the public. We are required to maintain competence as professionals. We have scope and standards of practice. It would be irresponsible or unprofessional to provide care that is less than standard. And finally, our training, our competence, our standards, all of that needs to be contextualized. They're not necessarily, and the risks that we're exposed to are not necessarily universal. So for example, an oncology nurse would have different training, need to maintain different competence, and have different risks associated with their position than an inpatient mental health nurse or an infectious disease nurse. So all of those things need to be contextualized. They're not universal. So the other way we look at where our the upper limit of our duties as professionals is with respect to the presence of conflicting duties. And in our practice, it is really likely that we are always in the presence of conflicting duties. We always have some type of duty to ourselves, to our family members, to our employers, to our colleagues, to the multiple patients we're taking care of. So we're kind of consistently managing different types of duties that might be conflicting with one another all day long, every day. And the fact that we have duties to multiple entities at the same time does not create a zero-sum situation. That I have a duty to my employer does not negate any duty that I have to my patient, and any duty that I have to my patient does not negate any duty that I have to my colleagues. So these aren't zero-sum situations. It just so happens that they sort of temporarily coexist. So in thinking about how we do determine what might be excessive or what might be unreasonable, it's important to note that heroic acts are supererogatory. So a supererogatory act is any act that providers might be praised for doing, but we can't be blamed for not doing. So nurses are not, and other healthcare providers are not duty bound to act in situations in which risk, given our training and expected level of risk and the practice environment we're in, is perceived as excessive or unreasonable. So the practice environment and the context help us determine reasonably expected risks and in that context, what an acceptable standard of practice might be. I want to touch briefly on this conflict that I hear, that I don't know that it actually exists, at least in the way that I hear it used. So the mere presence of risk to healthcare providers does not in and of itself create a conflict of duties, first and foremost. And when I have had conversations with nurses, it is not uncommon for me to hear Provision 5 of our Code of Ethics brought up as important in this conversation. And it is important, but it doesn't create a conflict. So Provision 5 is that the nurse owes the same duties to themselves as to others, including responsibility to promote health and safety, preserve wholeness of character, integrity, maintain competence, continue personal and professional growth. So the spirit of Provision 5 is really for nurses to be good nurses to themselves. That's the spirit of Provision 5. It is not intended in any way, shape, or form to create any type of conflict with other provisions, or to create a conflict between my duty to myself and any duty I might have to a patient. It is not intended. It is not meant to be used to pit our needs against anybody else's. That's not the intent. That's not the spirit of this provision. But I do hear it invoked. And while a lot of nurses are familiar with Provision 5 of our Code of Ethics, which is phenomenal, far fewer nurses are familiar with our social policy statement that actually says the patient's needs and interests supersede those of the institution or the nurse. Conflicts of interest are to be resolved in favor of patients. So this helps us think about, how do we resolve actual conflicts of interest? It does not say that supererogatory acts are expected. It just tells us that if a true conflict exists, as professionals, patients are our primary concern. Okay, so touching on some of the research that I have specifically done, looking at kind of the moral and ethical landscape that exists in the context of patient violence. So since it's often framed as a conflict, it would sort of meet the criteria for a moral dilemma. And I have been at several workplace violence committee meetings, and I've heard comments such as, nurses would say, I didn't know if I should protect myself or if I should protect my patient. So that was the impetus for this particular study that I'll kind of walk through very briefly. So a chaplain and myself interviewed nurses who had experienced physical patient violence within the last year. And we really wanted to look at the decision-making process they used to determine what was the right course of action when their patients became violent. Here's what we found. We found that nurses very much contextualized the situation, that they recognized patients as vulnerable in the situations they were in. They spoke about the power differential that they noted in their relationship with patients. They were very empathetic. And the conflict, when we sat down and allowed these nurses to talk about their experiences for a minimum of an hour, what we found was that the conflict between protecting themselves and protecting their patients was not a conflict. Every single person we talked to talked about their primary responsibility being patient safety, every single one of them. So what, you may ask, was the primary dilemma we found? Well, the primary dilemma we found was not even knowing how to interpret what happened. They struggled a lot with the dichotomous presentation of patient violence as one of two things. On one hand, it was a crime, and on the other hand, it was an expectation of their job. And that was the only space they had, the only frameworks they had to try to understand what happened to them. And those two dichotomous presentations were grossly inadequate to capture their experience. So in trying to figure out it's not that and it's not that, it's something else sort of altogether. And the dichotomous presentation of interpretations led to a dichotomous presentation of possible responses. On one hand, do nothing, and on the other hand, press criminal charges. And that was sort of again, that was the only framework that they had been given or exposed to or to understand this. But when we sat down and talked to them, it was very complex and they struggled to define their experience. They used terms like muddy and blurry and porous. They literally contradicted themselves. A participant would literally say, "It's the risk we take when we come to work." And 5 minutes later, in the exact same interview scenario, they would say, "And we shouldn't have to accept this." So it was rife with contradiction and muddiness and complexity and confusion. So again, there was this line that everybody wanted to articulate. There's a line that gets crossed, but nobody could articulate what that line was or where it was. What we found was that nurses had very distinct thoughts and cognitions about what happened to them, and they also had very distinct feelings. So all of them universally sort of assessed their patient as a potential risk of harm, specifically because their patient had an altered mental status for some reason. And they did things to mitigate risk. And retrospectively, and this was kind of fascinating, retrospectively, every single nurse we talked to, even those who had to lose time at work because of injury, who had to have surgeries, and who may never return to nursing, universally, they all said retrospectively that they think they made the right call because their job is to keep patients safe. They wished very much that things had turned out differently, but they knew they had done the right, quote unquote, right thing. But that didn't make it hurt any less. Again, they were extraordinarily empathetic, and they really struggled with the feelings that they were having, like perfectly appropriate and normal responses to violence, things like sadness, anger, fear, confusion, vulnerability. That is where they struggled with. They struggled with managing their feelings, really, in a professional context, because they knew they had responsibilities to their patient, but now they were scared of their patient. Now they were mad at their patient. Now they blamed their patient. And that was a confusing space to be in. So kind of implications that we took from this were that rectifying the conflict between human feelings and professional obligations was difficult. And here I will put a plug in for anybody who sort of responds to caregivers who are exposed to workplace violence. I would hope you would take from this an understanding that that is hard. Navigating the human feelings that they are having was hard. They also very specifically told us that pressure that they received from peers and supervisors was as distressing, and in some cases, even more distressing than the violent event itself. And we heard this from nurses who said, "I was receiving pressure to press charges. All my coworkers were telling me to press charges, press charges." And we also heard this from nurses who had coworkers and colleagues and supervisors who was saying, this is part of the job, don't press charges. So we heard this regardless of which direction the pressure was coming from. Both sides of the pressure itself was distressing. These nurses were trying to navigate their emotions and feelings, and the pressure that they were receiving was distressing. So my plug here would be to let any victim you come into contact with decide, number one, what happened to them, number two, what they're going to call it, and number three, what they want to do about it. And yeah, so we might need to really practice keeping our own values and beliefs to ourselves. In terms of like responses that they wanted or needed, they pretty universally said that everything needs to be taken on a case-by-case basis. They contextualized what had happened to them and knew others would contextualize things that happened to them. They endorsed that a one-size-fits-all approach to response is probably not effective. So standardizing or universalizing responses would probably not be effective. It would be effective to standardize and universalize a response process, but the response itself needed to be nuanced. And a big kind of takeaway from this was that sort of trying to polarize and simplify this conversation is probably not particularly helpful. Okay, so what other language and frameworks can we use? How can we sort of address this sort of middle space? People know they have duties. They also have feelings. What other language can we have to navigate this? So the kind of duty-based approach that I already mentioned is limiting. It really addresses us as professionals exclusively. It does little to help us address the kind of feelings and emotions. So what else is out there? So I'm going to suggest 3 different frameworks that we can sort of begin maybe incorporating into our languaging. So number 1, ethics of the everyday would sort of tell us that what happens every day is morally significant, and that morality does not only play out in times of crisis, it's with us all the time. Virtue ethics sort of helps us think about an ontological shift that we hope happens as people enter professions, that we literally internalize the values and ideals of our profession. They're no longer role-based expectations, but we've internalized them. So we don't act strictly out of duty, but we act to be a good person. I act to be a good nurse. So the question I would ask is, in any situation, would be, what would a good nurse do? And then the final framework is care ethics. So care ethics, first point, frames care as 2 things, a mental disposition, and also the practices we engage in. So it's both of those things. And it very much recognizes that care has emotional, physical, and cognitive aspects to it. So to walk through these in a little more detail, ethics of the everyday would inform us that people and our complex web of relationships are literally the locus of moral experience, that moral experience and personal experience co-constitute each other. Ethics of the everyday discourages the prioritization of kind of professional formulations of ethics over ordinary common sense experiences of life. And they would have us really think about how daily ordinary experiences of providing care on a regular, hospital unit on a regular day can inform our understanding of what we would constitute as big issues, like responding to risk. So the moral experience of providers and what they value and how they make decisions in everyday life ought to inform responses to extraordinary, quote unquote, extraordinary circumstances, is how the ethics of the everyday might help us frame thinking and conversation. Virtue ethics is kind of a framework that proposes that moral excellence and character develop over time through habits of action. And in this framework, actions have ends. I'm actually doing something, but the action itself is actually an end in and of itself, because it reflects on my character. So in a virtue ethics, a professional sort of framework of virtue ethics, it's also relevant that we perceive ourselves as communal and not isolated actors. So when I act as a nurse, I'm not only reflecting on my own values, I'm reflecting on the values of my entire profession. So I'm trying to be a good nurse. And how do we define what a good nurse is? Well, we have codes of ethics that will help us to make that decision. We also have input from the public. Um, Here are some of the virtues that the public has suggested they want from healthcare providers. And in a virtue ethics framework, virtue exists in kind of a mean state. So every virtue is characterized by a defect on one end and excess on the other. So I'll use an example of courage. So we are asked to be courageous as opposed to cowardice on one end or self-sacrificing on the other end. So we're asked to act in the mean state of those. And then finally, care ethics sort of shifts our thinking from prioritizing providers as having duties to patients as having needs. So it really recognizes that caregivers and care providers are in relation to one another, and that care relationships are inherently loaded with power dynamics. That all people, care providers and care recipients, have needs and are vulnerable, and care that is provided is based on need in this framework. I want to kind of skip through this a little bit because I'm being cognizant of time. So care ethics really calls us to be cognizant of the human relationship and the two people involved. So here are questions that I sort of have proposed that can be brought into conversations when we're talking about caregivers and risks that they face in the context of providing care to patients based on these different frameworks. Whether it's a duty-based approach, an ethics of the everyday approach, a virtue ethics approach, or a care ethics approach. So we have the conversation can be about what should be done, both individually and collectively, can be talked about in more than one framework, which is typically a duty-based framework. Okay, so kind of final thoughts so we can get to maybe some questions or comments that you all have. Patient violence inherently evokes an automatic emotional response. Our little amygdalas get fired. We experience fear, anger, distrust, vulnerability. That is a natural, normal human response. And it is okay to have those feelings. Emotions aren't necessarily the best way to make the best things to use to inform policies, for example, however, but they are normal, natural responses. And when we are exposed to violence from our patients, it's important to note that we have been violated. Something that matters deeply to us has been violated. And it's not uncommon for people to question their competence, to question their abilities, to question whether or not they're in the right profession, to question their beliefs about things. And in the context of patient violence, the potential for even more distress increases, because what I want to happen or what I think should happen is literally not what's happening. Again, these are very complex and complicated situations. So finally, like, what might be a moral response? So this is an ethics grand round, so let's talk about moral responses. I would encourage us all individually and collectively to not disconnect from the values we professed. Those can center us and ground us and guide us in every situation we come into contact with. Do not morally disengage. And ways we would know we're morally disengaging is if we start to blame others, to justify what we're doing, to shirk our responsibilities, to withhold care from people. That might be an indication to us that we are entering a morally disengaged space. And I should add that much of this is coming from Cinda Rushton, who is a phenomenal nurse researcher out of Hopkins. Be morally resilient. So what this involves is choosing to serve even in difficult circumstances. And this does not mean we are being complacent. This does not mean we're just going to accept whatever is thrown at us. It is more a framework of exercising agency, that this is the situation we are in, and I am choosing to move forward to try to make the best of it. Again, I'm going to circle all the way back to the very beginning, that words matter, to identify what it is we stand for and not what we stand against, and to always move forward in ways that preserve our integrity, again, individually and collectively. So what I would love to happen is, in any workplace violence committee meeting I sit on in the future, in any conversation I have, particularly about patient violence, that the conversation starts like this: we are here to provide the best care possible to every patient who needs it. Therefore, here's what we ought to do. That would be my kind of final note there. And that is all I have. I think we have like 10 minutes. I hope that's a little bit of time. But that's all I got, Julie.
Thank you so much. Really, really appreciate that very compelling presentation, and with incredibly complex issues. There are some comments in the chat, but I wanted to start with a question. From early on in your talk, you were saying that that a well-articulated dismissal policy would be better than a zero tolerance policy. And I wondered what you would suggest a well-articulated dismissal policy looked like.
So such a policy would be, number one, specific to, to patients. So again, we have different relationships to our patients than we do visitors or other people who might come into our institutions. So a well-articulated dismissal policy would sort of clearly lay out number one, a process to even begin the process of dismissing somebody. So that would be a really important, if a conversation's coming up, we need to dismiss this patient from our service, from our unit, from our floor, whatever. Here is number one, the process that we go through to make that, to determine if that's even a possibility. So number one, it would articulate a process that could be invoked if that was a desire. And such a process would likely have to involve very clear communication with patients and their designated, if necessary, their like designated surrogates. It would clearly need to establish handoffs and transitions of care. It's in most cases, in some cases at least, not legal to just dismiss patients with no follow-up care. So it would need to articulate a process, I guess, more than anything.
Okay. Thank you. How do you get buy-in from your organization, whose strategy seems to operate on a zero tolerance model?
I keep talking. That is all I can say with respect to that, is I keep talking, and I'm the squeaky wheel at every meeting where it comes up. That I just keep proposing that we at least have additional conversations, that I mean, it, when I'm in situations where people are talking about a zero tolerance policy, when I ask a simple question like who determines the line, like nobody can answer it. So I just keep asking questions and pushing and promoting other approaches. I can't say that I've achieved a huge level of success, but I keep trying.
Mm-hmm. Well, kind of related to that, that good question. I do have a question about it. You were talking about, for instance, when people are acting, being morally resilient as best as possible, of and yet continuing to experience the violence, and really struggling with this, trying to hold fast to the values of the profession and so forth. But um, what do you think is the role of the institution in terms of supporting, for instance, the nurses who are struggling to remain resilient um, and morally committed, and struggling with moral distress around this, and yet perhaps not feeling supported by the institution itself? Do you have any suggestions for the institution, or what could be expected? Hopefully.
So I might, Julie, try to address this one with like maybe like a specific example. So a circumstance that I think is not particularly unusual that patient violence occurs in, one of these two things. We have an elderly patient who has dementia, who's been medically cleared and is a custodial patient. Basically, we have nowhere to send this patient, and we all have custodial patients. So think of your custodial patients and why they're custodial patients. So we're taking care of patients in an acute care setting that literally belong in a different setting. We're taking care of patients who have acute psychiatric needs and acute sort of, I will put in air quotes, medical needs, because I think those are the same thing. But we're asking acute care nurses to now be behavioral health specialists too. So I think it would go a little bit of distance if organizations and leaders really recognized and validated that providers are being asked to do something they're not prepared to do. And then if they can acknowledge that, like, that opens space to maybe help prepare them. So if I, as a medical surgical nurse, am now being asked to also be a psychiatric nurse, then please provide me some training. That would probably go a long way.
Okay. Thank you. Nice thoughts. There are quite a few comments and discussion around power differentials and how they're inherent in the work environment, and wondered if you might address that a little bit in terms of sort of reframing the problem and the solutions in terms of power differentials.
I mean, I think most of us as healthcare providers are very acutely aware of the situation that exists, that we inherently have power in these relationships. Inherently, it is not even close to an equal situation. And I would point out that one thing that happens in the context of patient violence is that, at least momentarily, that power differential flips, right? If somebody is physically overtaking me, I am no longer in power. So the power differential, at least momentarily, is not what we're used to. And I think it's worth, number one, recognizing that we have been put in positions in the context of patient violence. We have been put in a position now that we are vulnerable in a different way than we're used to being vulnerable. So that, I mean, I guess that's one place I would start. I think we as providers are aware of our power, but we could sometimes navigate that power a little differently, and at least attempt to equalize in situations where it's possible to equalize power differentials. I'm a verbal de-escalation trainer, and it definitely happens that I have seen healthcare providers engage in power struggles with patients. So giving providers the skills to not do that is helpful.
Very good. We are going to need to stop there. It is the top of the hour. To the person who was asking about the care ethics slide, your slides of this presentation have been recorded, so you'll be able to go on the link at the Center for Bioethics and Humanities and be able to look at that slide again, which was a very good slide. So thank you so much, Dr. Copeland. This has really been very good discussion and very good presentation. The next Ethics Grand Rounds is December 14th. It will be on transplantation and ethics with Dr. Brian Jackson. So we hope that you're able to join us then. And again, thank you very, very much. We really appreciate your talk.
Thank you.